It's a pleasure to chair this final panel of the day on AI in the NHS from Promise to Practice. I'm Dr. Becks Fisher. I'm Director of Research and Policy at the Nuffield Trust. I think it's fair to say that the 168 pages of the 10-year plan contained rather a lot on AI. We're going to unpick rhetoric from reality in this session. We're going to be discussing how AI might be used to benefit the NHS and our population's health, and what is actually going to be needed to unlock some of those promises made in the 10-year plan. Before we get to that, we're going to hear from Steph Kumpunen, my colleague at the Nuffield Trust, senior fellow with us, who's going to start with a case study from general practice. This draws on research that we published just yesterday with RCGP. I think you've got summaries of it on some of your chairs. It was funded by software company Optum, and it explores how GPs are using AI in their work right now. So a kind of snapshot profile, the biggest survey of its kind to date. Then we're going to have a brief pre-record from Minister Zubair Ahmed, and then a panel discussion. I'm going to make sure that you get plenty of time for audience Q&A as well. So please don't let me down on this. I'm going to take a bet on you that you'll have lots of questions, give you lots of time for them. Please think of them now. Steph, over to you.
Thanks, Becks. Good morning, everyone. So as Becks has said, I'm Stephanie Kumpunen. I'm a sort of generalist health services researcher, health policy researcher at Nuffield Trust. Fairly new to AI, but a very interested and curious researcher in that space. I'm going to kick off this conversation with a very brief presentation covering how GPs are using AI. And really, this is just a case study before we get into conversations about how the wider NHS is using AI. So this presentation draws on a report that we've just published. You have copies of the summary on your chairs, and that was carried out in collaboration with partners at the Royal College of General Practitioners, and Nuffield's contributions were supported by Optum. Really looking forward to hearing any comments and questions that you have about the report. So I want to start by setting a bit of context. General practice, we've heard this today, is under significant strain. Public satisfaction is at its lowest ever, and GPs are reporting unsustainable workloads, much of which is non-patient facing. The government have identified AI as a key part of this solution for general practice, but also for the wider NHS and the 10-year health plan. But until now, there hasn't been a huge amount of research around the full range of these technologies and how GPs are actually using them. So in this study, we really tried to answer four main questions. So what proportion of GPs are using AI in their clinical practice? How are they using it? And what do they see as the main benefits, concerns, and challenges? And our research combined a UK-wide survey that was sent through the annual GP Voice survey, which is sent to all RCGP members. We had around 2,000 respondents this year, which is the largest and most up-to-date survey on the topic. And that was followed up by 5 focus groups with a convenient sample of around 24 GPs from England and Wales. There are many more detailed definitions of AI, but we used this definition in our work. So AI refers to machines that perform tasks normally requiring human intelligence, particularly by learning from data to find patterns and make predictions. Now let's get into some of the findings. Of all survey respondents, 28%, that's 598 GPs, reported that they currently use AI tools in their clinical practice. And breaking this down a bit, 13% of all respondents said that they use AI tools that their practice had selected and provided to them. 11% said that they had used tools that they had obtained themselves and independently of their practice. A further 4% said they use both, so that's practice provided and self-obtained, and the remaining 68% of GPs said that they do not use AI tools at all, and 4% said that they'd prefer not to say. I think it's really important to note that there's quite stark differences in adoption, and adoption is not uniform. We found significant variation in across regions, genders, age, and levels of deprivation. For example, GPs in England and Wales are more likely to use AI than those in Scotland and Northern Ireland. Generally, male GPs are more likely to use AI, and specifically younger and male GPs are more likely to use self-obtained tools, whereas middle career GPs are far more likely to use practice-provided AI tools. Those working in more self-described, socioeconomically deprived areas are less likely to have access to AI tools, and specifically practice-provided tools. And I think that highlights questions around whether or not AI can be the great equalizer that it's been sort of pitched to be. So AI tools in general practice are most often being used for clinical documentation and note-taking, possibly not a huge surprise to all of you. We heard that 57% of the 597 AI users reported this use case, and many of them said, over 2/3, said that they used it daily. typically through ambient voice technologies using tools such as Heidi Health or Accurix X Scribe or Lexicom. Professional development was the next most common use case. And that involved really just keeping up with clinical guidelines, writing reflections for training and appraisals, and testing clinical cases for learning. And they described using tools such as ChatGPT Study Mode, and Glass Health. And that was followed closely by administrative tasks at 44% of AI users. And they reported using AI for things like development of in-house policy documents and writing referral notes. And they used many of the tools that I've already described, but also tools like Claude, Copilot, Ankit AI, and Patches. You might have heard of some of these tools in the past. And our report goes into a bit more detail about several other use cases and other tools and the frequency of their use as well. We also gave GPs a list of potential concerns based on the literature and discussions we were having with experts. And some of the top concerns are there in the top row. And really, those are sort of inward-looking, focused on themselves. And they included things like concerns around professional liability and medical legal issues, concerns around a lack of regulatory oversight, both of which I think link to concerns around the risks of clinical errors or misdiagnosis. But you'll also see in the bottom row there that they were also concerned about patients, and in particular, patients' data privacy and security, their acceptance and trust in AI, and GPs were also concerned about supplier reliability, credibility, and data security. We also took away a few things from our focus groups, and those were really about how wider AI adoption is being held back by several barriers. It had appeared that localized approaches to governance were operating, and those had created a quite fragmented landscape where approval and adoption depended really heavily on decisions that had been made by ICBs, some of which encouraged AI and some of which banned it, and that created a real patchwork of adoption. No one in the focus groups had been formally trained in using AI, had practice-based policies on how to use AI, or really clear about the national guidance or regulation. And while some had been offered supplier-led training, but many were really unaware of other venues to seek out. And seemingly they turned up to these focus groups almost in hope that they might learn something about AI even by taking part in research, which tells you a bit about what's going on in general practice. So now all of this has resulted in several recommendations, and I'm just going to walk you through them in a couple of slides. And I'll start with a few recommendations for policymakers, which I hope we can unpick with the panel. Really, the first one is around working towards rapidly establishing national guidance to address some of the variation that I've talked about across the country, as well as really clear governance and regulatory frameworks, and which should cover sort of a range of different tools, administrative tools, clinical decision-making tools, as well as generative AI or chatbots as well. And part of this guidance, I think, might come in the sort of AI roadmap that's currently being developed. And some of the governance and governance framework and regulatory frameworks might sort of be touched on by the AI Commissioner's remit. But really, I think those are system level. And at present, it's unclear, specifically in how they'll practically help GPs who feel like they're really struggling on the ground right now, in part because those outputs from the Commission and the roadmap could take quite a while to realize. And next, I think it will be really important to develop structured training and education programs during medical education, but also for postgraduate GPs. And this would ideally be funded nationally, with regulators and medical royal colleges being involved in standardizing and specifying the content of this training. Thirdly, policymakers must take action to mitigate some of the risks that we're seeing around how AI use can widen health inequalities. And this should really be explicitly addressed in any guidance. Next, the 10-year plan suggests that AI will radically improve patient access. But what we heard in our focus groups and through the survey really was that time saved may reduce clinician overtime and or help limit or reduce workforce burnout, rather than immediately equating to several more appointments. And I think there's a big discussion that needs to be had about aligning the aims and objectives of AI being introduced in general practice. And finally, AI adoption will increase carbon emissions and electronic waste, and that conflicts with the NHS's net zero goals. I think any guidance that comes out will need to discuss these trade-offs. Okay, so a few recommendations now for AI developers and tech suppliers. Firstly, really focus on developing the AI tools that save GPs time in their routine work. We heard that this was their priority for now and in the next 2 to 3 years. The human-in-the-loop clinical decision-making tools are of interest and something they're keen to explore, but I think trust in AI, and what we heard was trust in AI really needs to come first and grow before those become something that GPs feel comfortable using. Another recommendation is really around integrating tools seamlessly with GP's electronic patient records, rather than tools that are standalones or bolt-ons that require a huge amount of copying and pasting and introduce risk of human error. The little monster there represents hallucinations, so really there was what we heard was a strong need to address and reduce hallucinations that are reported and ensure that the risks are emphasized in any training that's provided to GPs by those suppliers, and build in ways for GPs to be sort of triggered to check their outputs and avoid automation bias. And finally, co-design tools for GPs with diverse groups of GPs and other practice staff to ensure that it really does meet their needs and what they're looking for. A few reflections for GPs themselves. There are a few in the room, it seems. Think about developing interim guidance on AI until clearer and much more comprehensive national guidance is available. Local guidance really should focus on open discussion. We've heard a bit about practice provided, but also self-obtained, and there should be openness and transparency about how those are being used. Develop clear protocols to cover patient consent, approved tools, and really just think about reporting adverse events and try to build off some of the guidance that's already out there, for example, from the CQC. I can't emphasize this enough, but allocate time to evaluating tools, testing out tools, sharing learning, thinking about templates that you can share across practices, across PCNs, across neighborhoods to avoid reinventing the wheel. And finally, as AI becomes more integrated in general practice, I think it's really important to be transparent about how practices are using AI and to continue prioritizing those human elements of care that both patients and GPs really, really value. So in conclusion, the government knows that improving public's access to and experience of general practice will be key to the success at the next election. And I think this study has shown that there are some potential benefits to improve both patient care, but also the working lives of GPs, but these benefits are far from guaranteed. They're really quite big, widespread adoption challenges at the system level, and those include things like national guidance, clarifying issues around liability, providing training, considering equity during implementation, both at national but also local levels. And finally, AI adoption has really been on the rise, and in general practice, that's something we've been keeping our eye on. And ongoing dialogue and research is really recommended to understand what's working and what's not, so that the 10 years plans, AI promises can be sort of better monitored, but also realized over time. Thanks so much for your attention. We are lucky enough now to have a video. So in response to, or perhaps to foreshadow some of the conversations we'll have, we've got a video from Dr. Zubair Ahmed, Minister for Health, Innovation and Safety. This is about 3 minutes long.
Colleagues, I'm sorry I can't be with you in person today, but I'm glad you have such a strong cast list of people well placed to grapple with the question of how to harness AI's potential in our healthcare ecosystem. As you'll know, AI is a critical enabler across all 3 of our 10-year health plan shifts. And I just want to call out a few examples as to how we're going to harness the power of AI to transform healthcare delivery. The first example is working on ambient voice technologies, where my officials are working very hard to safely but rapidly scale it, so clinicians can spend less time on admin and more time thinking and with patients. The second example is our commitment to publish next year a new regulatory framework for medical devices, including AI, which will support faster and safer rollout of effective AI. And the third example is our commitment to implement a national AI strategic roadmap and in AI and social care, which will be adaptable and tangible. But without trust in AI from patients and clinicians, AI's promise to help patients, workers, and the wider healthcare ecosystem will not be borne out in practice. I think there are 3 key ingredients to establishing and maintaining that trust. Firstly, a relentless focus on patient safety. Secondly, regular and transparent engagement with the length and breadth of stakeholders. And thirdly, delivering the effective use of AI, not using AI simply for its own sake. On patient safety, we remain absolutely committed to ensuring the technologies are safe. The Independent National Commission looking at the regulation of AI in healthcare will ensure we balance our commitment to safety with innovation. And I know that Penny Dash, as Deputy Chair and the patient representative, will be immensely important to this work. On my second point, engagement. One success I hope you're all familiar with is the AI Ambassadors Network, which started from scratch in January this year and has now more than 11,000 people involved. Collectively, they're using their experience and talents to inform the development of the NHS AI strategic roadmap. And the final element I will mention in the context of AI and trust is the swift and effective delivery of AI services that benefit patients and healthcare workers. This requires a strong evidence base and a focus on the biggest healthcare issues. Getting this right will increase confidence and earn the trust of our fellow citizens. Hopefully you all agree, but if not, I want to know about it. Please do share your reflections today with my officials, as using AI for good is our collective effort for all. Thank you.
Great.
Thank you. Don't forget to be thinking of your questions as I introduce our fantastic panel. I'm banking on you guys. I'm going to take a chance. With us for a conversation now, we have Professor Alastair Denniston, practicing NHS clinician, but also head of the UK Centre for Excellence in Regulatory Science in AI and Digital Health, and chair of the National Commission on the Regulation of AI in Healthcare. Dr. Indra Joshi, Chief Development Officer at Optum, and Tim Horton, Assistant Director of Insight and Analysis at the Health Foundation. Now, I don't know if let's suppose somebody just around the corner on Victoria Street were reading this morning. Is 28% of GPs currently using AI a good number for you or not? Like, I'm seeing shaking heads. Like, I really don't know. I think you guys feel the answer to that is no. And so my first question to the panel, and Alastair, I'm going to come to you first and then move along, is really, how big do you think that gap is between rhetoric and reality? And what would your priorities be for closing it? It's 2 in 1, just to start us off lightly.
Yeah. Okay. So I think one of the first places to go with this is the challenge of using a term like AI. So that's not to undermine the entire premise of this panel. Don't worry about it. I think one of the great things about this report is it's actually quite specific. It's looking at a particular type of AI in a particular context. And I think there is a massive gap in reality in adoption if we just talk about AI in general. But once you start drilling in, I think you find use cases where actually the adoption is really accelerating. And I think, if you did this report again next year, I think that percentage will have shot up. And so I think this is an example where, yeah, there's a delta here, but it's really accelerating. I mean, I think if we look at where the opportunity of AI, so I'm just going to zoom out for a moment, Becks, I say the opportunity for AI, whichever form of AI it is where we have a defined need meeting technological capability in the context of system readiness. And I think as I look around the room, you're all kind of influencing the health system in different ways. And you may or may not be experts in the technological capability, but I'm pretty sure you will be experts in some of those defined needs and being able to define those needs and communicate them. And you will also be the change makers in terms of system readiness. As we've heard from the Minister, a number of the things that he's describing there is an effort to improve that system readiness. And it's a bit like a bridge. You can build one side, and that's the technological capability. But if we don't build the other side of the bridge in terms of system readiness, and hopefully in the right direction so they meet in the middle, we won't get very far. So I think that's probably enough from me, Becks, at this stage.
Brilliant. Thank you. Indra.
It's a great question, isn't it? And I think I'm quite glad that we've actually got some good data. So I remember setting up the lab back in 2019, so the NHS AI lab, and we did a survey at that time looking at how many clinicians and healthcare workers used AI, and it was quite small, so it was in the single digits. So it's good to see, albeit 6 years later, that it's now in the double digits, but the low double digits. So I agree. I think we will see a change over the coming years. I think it's really important that we don't lose sight of some of those concerns, especially the one around liability and the integrity of the record. And I'll come and talk a little bit about the work that we're doing. So we haven't rushed as a company to go and, say, here is an AVT or an AI type technology. What we've done is really listen to a number of our customers and users. So for those of you who don't know Optum, we provide GP software, formerly known as EMIS, in about 60% of GPs. We're in 85% of community pharmacy and 15% of community healthcare. So a lot of what our customers and our clients are telling us is actually we want to know that when we're using this technology, actually we know we can trust it and it seamlessly integrates into the record, as Stephanie, you've alluded to. So that's really good. So we've been working on how do we evaluate those technologies, work with MHRA and the AI Commission to provide that concrete framework. We go round and round in circles about thinking, well, this is what we should do, but we don't often talk about how and who does the should. And that's one of the things we're focusing on. So I'm hopeful that over the coming months, we'll be able to bring that to reality and really showcase and hopefully bring the GP community and the community pharmacy community along with us to say, this is how we can deliver.
Brilliant. Thanks, Tim.
I guess if you were sitting in Victoria Street, you might think that 28% is too low. And that's the kind of resistance or intransigence of professionals and providers. I think what your survey shows is that there's a number of barriers to that number being higher. And just picking up on Alastair's characterisation of system readiness, how are we supporting with the training and the governance? How's the regulatory regime addressing some of those concerns about liability and safety? How providers, suppliers, as Indra was describing, working with providers to get things right for them. So I think that the weight of this isn't just on, in this case, GP practices, but the provider sector. It's on the whole ecosystem to tackle the barriers in order to get that number up.
Brilliant. Steph, did you want to?
I can give a quick one. Yeah, perfect. So coming at this as a researcher, we've got sort of 3 small data points that we can look to see adoption rates over time. So in general practice, we understand that sort of the adoption rate was around 20% in Feb 2024, 25% in Jan 2025, and just now around 28%. So let's assume that 5% increase over time. Fast forward 9 years, what does that take us to? 75% adoption, assuming all goes well, right? Is that a good number? It's probably not in line with what policymakers are expecting in 10 years' time, and it may not be what ends up happening. But I do almost think that adoption rates are maybe the wrong question, and it might be, better metrics for measuring success might be something like percentage of GPs who are confident in recognizing risk, or knowing what to do when something goes wrong, and really focusing on metrics that are more aligned with confidence and awareness of risk and potentially even benefits and how it could change the ways that they work might be a better focus for policymakers possibly to be thinking about to measure change. Thanks.
Brilliant. I'm going to pivot slightly. We've talked a bit about what clinicians are or aren't doing, but I think completely fundamental to this question is what we as individuals, the public, patients, feel is acceptable. Tim, I think you led some analysis and surveys looking at both staff and patient perceptions of AI use in healthcare. What did you find?
So the public are, on balance, up for AI in healthcare, staff as well, more so than the public. And in fact, you've asked me about the public, but that's interesting as well. You might be thinking, staff are sitting there thinking, oh, is this going to take my job? In fact, we see greater enthusiasm, not uniformly shared across all occupational groups, but a high degree of enthusiasm. Despite the public being, on balance, up for AI in healthcare, there are certain groups that are noticeably less positive, socio-demographic, economic groups, D&E. Interestingly, younger people age 16 to 24 seem to be more negative about the use of AI. We're going to be doing some qualitative research next year to try to explore what that's about. But there's broader social research showing metrics of trust in that group are quite low generally. Women tend to be slightly more negative about AI than men as well. So I thought it was interesting in your report that fewer female GPs reported using AI as well. So it's really important that we're engaging with these groups to understand those concerns, because this has got to be something that works for everyone, and where there are concerns that can be addressed, that's really important. Finally, when we ask, the public say they don't know a huge amount about AI in healthcare, but when we ask them what they think the biggest benefits will be, they tend to say the potential to free up staff to spend more time with them. They also think it will give them quicker results. When we ask what they think the biggest risks are, they tend to highlight, firstly, the potential loss of a human dimension in healthcare. And in fact, that's not just AI with tech in general. We see things like chatbots, which are seen to come in between the relationship between a patient and a clinician, tend to be less popular than technologies that more ostensibly connect the individual with the service, like remote devices for communication and so on. The public are also worried about safety and the accuracy of decision making. And I guess that's partly why it's so important, the work that Alastair's doing, thinking about how do we get that regulatory framework not just right substantively, but that it seemed to be right and that there's trust in that too. So I think it's a potentially positive and benign environment for moving forward with AI in healthcare, but with specific concerns that are going to need to be addressed to get that right.
Tim, that's so interesting. I could see a lot of kind of eyebrows raising and folk looking surprised with your stat about younger folk. Alastair, I wanted to come to you on this kind of area of building trust, because I think trust can very easily be lost. We can all think of big NHS scandals where trust has really fallen off a precipice, and once lost is very hard to regain. Your task with the fairly Herculean effort, I'm sure, of building a regulatory framework for AI. So I'm guessing you're thinking an awful lot about how you kind of maintain that trust. Please talk to us about how you're doing that.
Yeah. So you'll be relieved to know that it's not just down to me. There's the commission, it's a national commission with kind of representation, the 4 devolved nations, great representation across the health sector, different components of the health sector, tech, the regulatory system, and across different bits of government. Because of course one of the challenges and indeed opportunities of AI is it's not a neat technology that just sits in the health sector. And so as soon as we start talking about regulation, we also have to think about which is kind of health-specific components of regulation and which other kind of cross-sector types of regulations, such as we see in Europe with the AI Act. But coming back to your point, Becks, I think I wouldn't at this stage, given that the Commission's not due to do its full report till May of next year, I don't want to prejudge the kind of specific outputs, but I'll tell you what I would hope that it is characterized by. And that is that future regulatory framework for AI in healthcare should be, and I don't think many of these will come as a huge surprise to the audience, should be safe, it should be fast, and it should be trusted. Trust does need to be earned, and so that's why I was starting with safe. This is not a kind of comms exercise to persuade people to use AI. We need to have a system which ensures that people know that it has gone through the same level of evaluation as we'd expect for a new drug or a new other technology. One of the things I note in the debate here, and I think we can all fall into, is because AI is, we have a sort of instinctive reaction to it, and I think rather than a purely rational one, unlike, say, monoclonal antibodies or GLP-1 agonists. And I think that's for 3 reasons: imagination, extrapolation, and desperation. So I think, imagination is fairly obvious. It's kind of, it permeates our kind of literature and films. Extrapolation is actually because it's so successful in non-safety critical areas such as kind of entertainment, etc. And we see it working so brilliantly. So why of course it can apply to health. But the third thing I think is, which I have a lot of sympathy with, but I'm also perhaps the most dangerous, is desperation when we're looking for kind of magic solutions and instant solutions to our massive capacity demand mismatch. So this is not at all to take away from the potential of AI, but it's just to remind us all, including us in the room, that we may have a slightly sort of instinctive reaction, either very positive or really quite negative to this technology. So just there's a moment to come back, and I think in the regulatory system too, we need to make sure that we have the systems that show that are not based on the kind of sales pitch, but really do assess the opportunity of that technology. I think fast matters because actually there is a big opportunity here, and what we're doing now is less than perfect. We've heard that through the morning. So any technology that pushes the dial to improved care, we don't want to unnecessarily delay that coming through. We need our systems to be much more optimized for these kind of technologies so that people can build them and know that the NHS is ready to use them. And then trust that you've already pointed to, and all the data we're hearing this morning is so helpful in terms of understanding kind of who we need to communicate to, who we need to engage, how we build those structures so that people can feel assured that they have trust in the system.
Thanks, Alastair. Indra, I wanted to come to you to kind of flip the question slightly from the perspective of working with a company that is a software developer and has a perspective, I'm sure, on kind of AI tool development. We heard very clearly in the work that Steph presented earlier that clinicians have some concerns. They're worried that these things will just be bolt-ons, they won't integrate with the records they already have, but actually they're just worried about the quality of the outputs they're producing and the medical legal liability that involves. So I'm wondering, from your perspective as a software company, what do you think the role of technology companies is more broadly in developing tools that clinicians will trust to be able to use with patients?
I mean, my simplest answer is involve clinicians or involve whoever your end user is, and that goes for any technology regardless of what it is. And I feel quite excited because I know you asked me to be a bit excited, so I'm trying to loop it in. We've come a long way. We genuinely have come a long way. And I think the advent of LLMs has changed the dichotomy, the relationship with medicine overall. Medicine's traditionally been quite patriarchal. You know, you go to a GP or you go to a clinician and they're right and you're there to kind of take their knowledge. But with these LLMs, these whatever you use in your pocket, that world of knowledge has opened up to you. But what remains key, and one of the things that we feel is really important, is that single source of truth. So your data and your outputs are only as good as what you put in. And that's been the basics of, coding for a number of years, for decades. But what happens when that box that you start training your models on we talked about hallucinations, it starts spouting junk. So that's where I think software companies really need to take responsibility and take a bit of ownership. Like you have built, if you're a record builder, so we're an EMR vendor, take responsibility of that single source of truth. Be really clear what's going in, be really clear who's using that data, and involve your end users. So if it's clinicians or if it's admin staff, like what is the thing that you want that's going to be most useful? People talk about triage. Triage is really helpful. Well, actually, triage is only really helpful when you've got time and situation. Actually, a general symptom checker, okay, great, I can discover I've got a UTI if I put 3 or 4 things in a model. But actually, what's important is, did I go to A&E 2 days ago because I had crushing abdominal pain? Did I have a fever? Have I already called up my GP to try and book an appointment? And so time and context is really important in those things. And actually, a recent event I was at in Northern Ireland, Linda, the GP receptionist, she was the perfect triage. She didn't need software. You needed the human who knew, when this lady calls, I know exactly what's wrong with her and I can filter her in. So and the bottom line is, yes, technology and software can prove and helpful, but actually don't forget the people and who you've got who actually know the context and can help with the technology.
Brilliant. Steph, I wanted to draw us back to the work of it that you presented earlier. NHSE and DHSC are busy developing a strategic roadmap for the NHS with input, I understand, from plenty of others, and this roadmap is going to deliver the host of commitments made in the 10-year health plan. As they start their engagement exercises, I'm curious to understand what key messages do you think, GPs, I'm asking you to channel slightly what your understanding is from the research evidence you gathered, but what key messages do you think GPs would want those roadmap writers to be hearing?
Great, thank you so much. As of late, I've been dabbling in ethnography and trying to become a bit of an ethnographer, so maybe this is a good way to help it's trained me to channel my sort of inner GP. So really, we heard 4 main points that were really important. And they were around guidance, around liability, around training, around equity, things we've already covered, but I'll go into a bit more detail. GPs weren't a homogenous group. Their red lines were really varied about what's acceptable and what's not. And I think that'd be really important for anyone, any policymakers, but especially the roadmap to hear that people are in different places. But one thing that came through was that they all wanted to be able to use tools safely and responsibly, regardless of which tools they were using. And they welcome clearer and much more practical national guidance. Recently, there's been a supplier registry that's been produced for ambient voice technologies, and that's been, I suspect that will be hugely welcomed by them, who are being, so their doors are being knocked on daily, saying, oh, try this tool, or try this tool, try this tool. They don't know which ones are approved. They don't know which ones would work best for them. And having something like a really practical registry will be welcome, no doubt. But those tools and those sort of practical guidance needs to move beyond ambient voice technology, where we're seeing the biggest gains happening, and they need to move to really tricky areas like clinical decision making. They need to move beyond sort of, they need to cover a range of tools, but also a range of tasks. On the points around liability, that this was really one of their biggest concerns. There are a range of statements out there, BMA, GMC, that have essentially given sort of suggestions around what the principles should be around safe and responsible AI use, but they're not comprehensive, covering the range of different functions or tools and tasks that GPs could be using them for, and that's probably a big gap. They want clarity, GPs want clarity around personal professional liability of what goes wrong and what the implications will actually be of when something does go wrong. How will it affect them? And that's clarity they just don't have right now. In terms of training, so you might have heard that Mr. Ahmed there had mentioned an AI ambassador network, and I joined that network because I feel like I learn a lot from it, so I'd encourage you to if this is an area of interest for you. And I'm aware that training exists and bits are put out over time, but to access that training is very difficult. The spots are limited. Sometimes they happen for short notice. I think GPs want, firstly, a basic understanding of what AI is, and then they need to work towards understanding the tools that are in their practice and really honing those, learning how to work with them so they're not wasting their time, so they know how to check outputs, so they know where the sort of gaps might be. And I think AI sort of developers and suppliers are really well positioned because they know their tools so well to do some of that training. The challenge is that they're not always perceived to be reliable or trustworthy, and tools, they're being sort of, GPs are having the doors knocked on and said, oh, try this free tool or try this low-cost tool. And I think what they're really skeptical about is what that cost will be in 5 years' time, and that's a big worry for them. So I guess that sums up, there is a huge amount of training that needs to happen, and I think that there's a national offer that needs to sort of be fair and distributed equally, and then finally that brings us to a point around equity. I think that was practices in deprived areas have less headroom, generally, and so meeting requirements around having a clinical safety officer, having someone complete a DPIA. To procure AI tools, you then need to fill something called a DCB 160. And what I've heard is it feels too much. We've got a really nice quote in the report saying you need a degree and to be able to complete some of these documents. And in particular, that hits hardest for practices in deprived areas. And I think what I heard come through time and time again was really that
GPs are really quite worried about widening the digital divide that exists already, especially with patient-facing apps. And they also worried about how patient data would be used and how securely that would be stored. And that was they were protecting their patients' interests in this case. So reassuring them around patient trust and where that data is will be a huge part of making sure that they trust AI.
Steph, thank you. I want to pick up on that equity, and Alastair, I can see maybe you want to come in. I'm just putting you collectively on standby that this is the last bit of work I'm going to do because it's over to you in a moment. But Alastair, come on in.
Yeah, there were some really, really, really important points there. I think just wanted to touch, if that's all right, Becks, on some other additional points on equity and maybe just some other pointers in terms of training. Equity, you've touched on in terms of the system level and the sort of gap between, say, a large, reasonably well-resourced, digitally mature trust, say, who may have a kind of very strong digital team, may even have some form of AI officer or kind of definite AI experts, being able to support that decision-making process, including putting things like DCBs through, etc., and DPIAs, versus a small, few-handed GP surgery where it's just like, even though some of these things are legal requirements, it's like at the long end of a long list. So I think that needs to be addressed, because I don't think the answer to that is to go, oh, well, we don't really mean it when we say it's a legal requirement. It's okay for you to kind of, not do these safety checks. That's clearly not fair, but at the same time, that's not fair on patients, but it's not fair on the surgery to kind of put an unreasonable burden. So I think that needs to be looked at. In terms of the point around equity in terms of our patients and public that we serve, some of the work that actually Indra and team funded when you were at the AI lab, there was a whole series of programs around trying to address at really quite an early stage in our kind of AI transformation to highlight issues around equity and to identify and find really practical solutions. And I'm really excited to see some of the work that has come out through that. So I just wanted to highlight that. So there's a much greater understanding now of the impact of training data and the way that essentially machine learning models imitate what they see, the pattern recognition. And so we understand much better the need for inclusive data approaches, which actually the NHS, more than many health systems, is well able to service and make sure that people are represented in those data sets and therefore that their AI systems work effectively for them. There's this concept of health data poverty when you're not represented in that space. And there are specific initiatives, again, one funded by Indra's team at AI Lab. It's called Standing Together for Standards for Data Diversity, Inclusivity and Generalizability by a brilliant team. And then there's also, in terms of training, I just wanted to point to issues around, we've heard the Ambassadors Network. There are NIHR fund various things. There's an incubator for AI and digital healthcare, which I lead, which does regular seminars, etc., which all are free. And the other gap we were talking about is around AI implementation. And one of the things I'm really enjoying doing now is running a master's, again, with a great team around AI implementation in healthcare. And I think that's going to be a real growing area. So we have loads and loads of courses around AI development, which are brilliant. But I think one of the things that maybe Steph's pointing to as well is that training around how do we safely implement these.
Yeah, Alastair, thank you. Right, the floor is collectively yours. Hands up, folk. Yeah, we're going to go over here first in the green and blue. You keep your hand up, then we know where the mic's going. Perfect, thanks so much.
Hi, thanks, Becks. My name's Luke Allen. I'm from Oxford. I'm a GP. And I lead the Global Primary Care and Future Health Systems team, and we're doing a lot of work on AI and supporting countries and systems around the world who are making bold claims and failing to back them up mainly. But I really loved everything in this panel. Thank you, it's great. And the diversity that comes through in terms of GPs have got different red lines, and the use cases and what we mean by AI, it's this huge, huge umbrella term. I'm most interested in AI for clinical decision support because it's the most spiky, it's got the most risk, it's got the most potential opportunity. And I think the challenges there are huge, but they're not technologically or insurmountable. And with the right regulation, we can get to a place where actually adoption would rise because GPs are really looking for help because primary care is complex and LLMs, on the face of it, could perform quite well. I've got 2 questions for the panel. One is, for things like AI tools that look at a mole and say, is it concerning? It's very narrow and quite easy to kind of regulate whether or not that's safe. What GPs really need are much more general purpose chatbots where I can ask about what's the sensible differential diagnosis, can you sense check my thinking on this? As the report shows, it's already been used for lots of cases. How do you approach regulating a much more general purpose model when the safety is kind of all over the place? And the second thing was, how much faith should regulators put in GPs to make the right decisions? It sounds like we're going to be quite strict, but actually GPs are already trusted to prescribe dangerous medications and do all sorts of risky things. How much faith should we kind of philosophically as a country put in our clinicians to use these tools appropriately, or how restrictive should we be?
Luke, thank you. I'm keen to get a couple of questions in. So, Alastair, panel, I'm going to put you on standby for the 2 questions we got in one already. There were more hands up. Yep, just in the stripy jumper in the middle. Thank you.
My name's Pollyanna. I'm from the British Psychological Society, and I'm really interested in what the panel thinks about the people coming forward seeking help with health problems using AI, because our members are hearing increasingly that people are using a human therapist as the last resort and going to AI before. So I'm curious what the panel thinks we need to do to help those people.
Fantastic. Thank you. Tim, do you
You're
want to start us
looking
off?
at me.
I am, yeah.
Well, just
sorry.
picking up on that last one, it's really interesting because I said one of the public's concerns was about the human dimension of care, but obviously the public are totally different as well. And what's really interesting is in certain fields or for certain types of users, there's obviously something that's working for them about interacting directly with AI. In the field of mental health, for example, there's evidence that some kinds of users prefer talking to a chatbot, will disclose more. Other kinds of users feel it's fairer, less judgmental, less risk of bias, and so on and so forth. So it'll be really interesting to watch how norms change around all of that. And the overall picture I gave earlier shouldn't be taken as applying to everyone. It's really interesting to see where that goes. If it's in a world of direct-to-consumer AI, I think then there are risks and issues around that and the regulation of those products too. I mean, I'll leave the other questions for Alastair, but just more generally on the regulatory piece, how much weight do you put on clinicians? You could broaden that question, how much weight do you put on providers? You know, it's clear that the regulation of AI in healthcare is going to be predicated on the capabilities of providers and clinicians to not only do stuff well, to implement it well, but to monitor it and to govern it well. And I think that's a really critical question as we put in place a regulatory framework. It's not just about the rules and parameters of that. It's about how we ensure the system can actually operationalise this.
Indra, you were looking like you wanted to come in as well.
Yeah, I mean, I think when it comes to mental health, we're quite fortunate that we in the UK have bodies like NICE and CQC and others. So actually, where people get a little bit confused is this a service, is this a digital therapeutic, or is this a standalone product, B2C? But actually back in, what was it, 2018, wasn't it? Looking at my ex-PhD colleague, we put out the framework of what evidence is needed for these different types of products, and those also apply to ones that use AI or machine learning. So we're quite fortunate that we're working not from the bottom, but from a level of understanding in healthcare. And so I think, yes, there'll be a change, and I think my challenge to Alastair and the Commission is, what do you start doing when you've got agentic AI? starting to make its own decisions based on that and ordering things. I don't think we've quite got there yet in healthcare, but, you know, it is the future. I'm going to let Alastair answer the regulatory question, then I'll come back because I've got views, but...
So I was going to, yeah. So, yeah, I was going to say, Becks, if I can start the regulatory response, and then I'd be keen to pass to you, Indra, just because I know you're doing some work in this space, in the more advanced models. So, again, the good thing about doing the commission is that I don't have to come with all the answers. So actually, if anybody has answers to the question that was asked, well, I'm really keen to hear from you. No, and I mean that seriously. I think this is working out how to regulate new technologies is not something that the regulator alone is equipped to do. And I think particularly with AI, and actually you touched on this and Tim did too, I think we need to really look at system-wide in a way that we've not had to do before. And in broad terms, you could look at who is best placed to understand the risks and the benefits of a technology across that whole pipeline, the whole total product life cycle, including to the use in the real world. Who is best? So who's best to understand that? Who is then best in the position to detect when something's not working as it should? And who's in the position to mitigate that? To also understand where there might be perverse incentives, where people, wherever you are, including whether you're a clinician, might not want to report stuff. So what is it that we need to do there around being cut? Oh, right, that's better. What about understanding and attitudes and some sort of safety net around that? And then look at how do we divide up those responsibilities and duties, both legal but also non-legal, across product. So that's really the product manufacturer, the professional who is using the product, unless it's direct to consumer, and the provider. And that involves all those bodies themselves working together and helping design that system, and also involves the regulators. So, that's would be the MHRA around the product. Around the professionals, it's groups like the GMC and the NMC and more. And provider in England would be CQC and equivalent bodies in the 4 nations. So that's the kind of 20,000-foot view, what that might look like. And it's going to, what I'm keen to do is that we avoid redundancies where basically everybody's trying to do the same thing, which is hugely burdensome for innovators and manufacturers. But I'm also trying to make sure we avoid gaps where everybody thinks it's somebody else's problem to look at. Quick answer to your specific question around then, so that's a bit more around the responsibilities. So we would, I think it's really critical that we don't say, we'll do everything at the product level. Because, as professionals, and you highlighted GPs, as doctors, we're used to taking responsibility. We understand that the tests we do are imperfect, and part of our ability or judgment that we try and do the best job we can is to interpret all these complex forms of data to make the best decisions aligned to the patient's own wishes and priorities. And that's a highly nuanced judgment. And I see AI fitting into that, not replacing that. I think I'll probably better stop there. And,
Alastair, I know you could go back to Indra, but I'm quite keen that we get to lunch on time, but also you have some more opportunities to ask questions. So hands up again, there were more. Yeah, just over here in the white, and then we'll come down to the front and then back to the panel with brief answers.
Okay, I've been told to stand up when I speak. I'm Professor Alastair, Professor of Health Technology Assessment at Coventry, which is the world-leading MOOC provider. What do you think about the care sector and the use of AI there, where you have non-regulated, so they're not professionals, you have hospitals discharging early into the community? How can we address that, and who's thinking about that at the moment? Because I really hear no dialogue going on in relation to that group.
Brilliant, thank you so much. Takes us in a different direction. And Liam, down at the front here.
Thank you. I'm Liam. I'm a GP by background. My question's about the role of AI in health inequalities. So whenever we talk about AI alongside health inequalities, we often jump into how we're all scared it's going to make things much worse. But actually, do the panel think there are opportunities for inequalities to be reduced through using AI? I think one short example is often all of the information that we provide patients with, whether on leaflets or web pages, etc., is very hard for patients to understand because it's not tailored to their health literacy, their cultural background, etc. Is there a role for AI in places like that where we can actually use it to reduce inequalities?
Two great questions. They're going to be our last two. Who wants to pick up first? Tim, you're in the firing line again.
Just on that last one, I'm a huge optimist about this, and I think, yes, there's huge potential of AI and technology to drive down these inequalities. You're absolutely right. Think about the way it could tackle language barriers for people with sensory impairments, et cetera, et cetera. Yes, there are some entrenched barriers around different income and wealth and your ability to purchase technology privately. Yes, there are literacy barriers. For many types of barriers I look at, when you think, how would you tackle that? You can immediately think how AI itself could help in tackling that barrier. So this is something we've got to worry about. I think particularly we've got to just understand why people in lower socioeconomic groups seem more suspicious of this and engage with those concerns. But I believe AI its net effect over the long term will be to drive down inequality rather than the other way.
Indra.
Yeah, and I would just add to that, think about the things that aren't clinical, like document filling. A lot of problems people have are socioeconomic problems, and how do they navigate the system? That's hard, that's complex if English isn't your first language. So actually it does have a huge benefit there. The only context I would add in translation, and we've seen this in some of the evaluation work that we're doing, is a phrase when translated from whatever language into English doesn't necessarily mean the same thing, and actually people experience pain in different ways. So we've got to be quite careful when we do that, thinking, oh, this person means this, because at the end of the day, it's just a machine. And so we should still, at this point in time, keep a human in the loop. I think that's important. Going back to the social care setting, I think we tried this when I was in the NHS lab to really try and fund technologies into the social care sector, but what we found was it's quite hard because of the lack of structured and organised data. And if you go back to the fundamentals of what AI is, it really is about using data, looking at patterns, predicting, etc. And so I think I would say, what are we going to do to look at really investing in that technical and that data architecture in that sector to enable more use? But there are a couple of technologies like Serica who do great work in sort of allocating humans across the board. So work is coming. I think there's lots of things there, but yeah, we really need to think about the data architecture in social care.
Fantastic. Steph.
Yeah, really quickly, thanks. I'll just respond to that last question, Liam. We heard two really, really nice examples of how access to care was enabled in an equitable way in our study. And one was really around communication tools and this idea that ABT can cover most languages. GP was saying that she had carried out a consultation in Urdu and had kind of half expected that, gobbledygook would come out, and it was a perfect translation, and the summary that was produced was great. And she was shocked. And she said, wow, that was just... But then we also heard that Welsh as a minority language isn't always picked up. So there are challenges there. But also, GPs were describing how they were able to produce outputs in real time in lay language that they could then text. And it was a helpful record for their patients, especially when there are complicated issues that were covering potentially a double appointment where there's lots covered. And, it's hard for them, for everyone in the room to sort of capture what's been discussed. And that was sort of a benefit that they sort of suggested of using those type AI tools for that. Yeah.
Fantastic. Steph, thank you so much for starting and ending the panel. Thank you all for participating. Thank you to our brilliant panellists. And Thea is just going to give us a couple of final words before we thank you all for coming and release you to lunch. But thank you, panel.
Yes, literally, I never would stand between anybody and their lunch, certainly not myself. To say thank you very much for coming. It's been a real pleasure. The debate's been great. It's been different. There's a lot of very boring debate, and it's been good, so thank you very much for taking part in it. Really importantly to us, you're going to have a little survey that will pop into your inbox. I'm looking, is that right? Pop into your inbox. I think it's got 4 or 5 questions. They're really easy. We'd really like you to answer them. It will really help us in the future, so please do. Thank you once again to Optum, who are our sponsor for this event, and thank you for taking part, and lunch is next door.